screens, both at work for the first time in 3 months. Our Steph is done with maternity leave, so we're very happy to be here and excited to hear a case and have two people volunteer to discuss with us. I have if anybody has a case, that would be wonderful. We have a couple of backup cases as well that we could present. So most importantly, we'd love to have two discussants as always. So in the meantime, I wasn't able to catch the VMRs earlier in the week, but I want to just share some reflections from an experience I had yesterday, which was taking care of a patient that looked very familiar. And so I searched the medical record, and I had taken care of him 6 years ago, which was, or actually close to 7 years ago, in my first year as an attending. And it made me kind of think about how we grow and develop over years, even when we're done with training, and how much your knowledge changes, how much your style changes, how much the medicine itself changes. So as like a quick funny piece of reflection, I had recommended considering dabigatran or rivaroxaban for this patient. Whereas like, dabigatran we just don't use anymore, and I haven't heard of it in many, many years. The amount of kind of, I guess, detail with which I was approaching the case was potentially different from what I would do now. And maybe that's just me kind of deferring some of that attention to the residents now that I'm a little bit more experienced of an attending. And I also noticed that some of the things I had written like revealed some degree of like clinical naivete, where I definitely felt like I have kind of grown and just matured in some ways with more experience. Whereas other things, it was amazing. Like I had the neuro exam I had for that patient was like, I think better than the neuro exam I could perform now, which actually motivates me to try to attend Tuesday VMR more consistently, just for some good CME from Kirtan and Maria and Aaron. So it was just interesting again that there's so much room for continued growth and learning, even when you're done with training, but importantly, just recognizing that some of your skills actually atrophy. Like you can get worse at things over time if you don't have a sustained, exposure, sustained deliberate practice in a certain topic. So, a lot of things we do to learn, it's not just to like keep getting better, but scarily enough, some of it is important to like not get worse. So anyway, it was just an interesting kind of out of body experience to like look at my 6 years ago self or 7 years ago self from an interesting perspective. Thank you for indulging that continued self-reflection. It seems like we still don't have any volunteers to discuss the case. I would actually maybe, Kirtan, you had mentioned being open to being one of the discussants. I do have a backup case myself too that I can present to Steph and Kirtan, and let's have one other person step forward and help Kirtan and Steph with my very, very tricky, actually it's a really neat case. So I would be very excited to share it with whomever. All right, who would like to discuss with Kirtan? Let's give it another few seconds. Activation energy. Anybody? Thank you, Anne Marie. Um, uh, do you? Why don't we save your case for next time? I've actually been wanting to um, share this case for a while. But if you want to co-discuss with Kirtan and Steph, um, and have a power triumvirate of clinical reasoning, um, that would be awesome. You want to do that?
Cool. Happy to help if that's needed, but I'm happy to just observe too. I just wanted to offer the case in case you wanted to discuss, so I'm happy to save it for later.
I appreciate it. Well, yeah, however much you want to participate, you can just hang back and drop some bombs here and there, or take a more formal role. But yeah, Gabriel, if you want to go ahead and share the screen, and I'll start telling the story. So this was a 61-year-old man. He had chronic kidney disease, stage 5, not yet initiated on dialysis. And he came to the hospital with 4 days of, the word he used was twitching in his face, facial twitching. So in fact, I'll actually just pause there and see if anyone has a schema for twitching.
And Kirtan, let me ask you, since you and I are pairing up on this, do you want to just each of us take turns on each aliquot, or do you want to kind of give your thoughts first and I can just chime in, however you feel like the flow would go well?
Yes, so whatever you think is appropriate, I'm happy to do that.
Why don't we let you kind of just chime in with each segment, and I'll kind of build on what I'm sure will be really great thoughts and teaching points from you.
Yes, sure. So first of all, since Zavan has been saving this case for quite a time, I'm scared that what kind of case it can be. So it has to be daunting case. So now talking about the case, the patient has CKD and now the patient has facial twitching. So I was wondering that how the CKD can be linked to the facial twitching. So is the process indeed related to the kidney failure, or is it related?
We lost Kirtan for a moment. I'm sure he'll be back, but I assume his point was going to be related to this advanced CKD or not, which I think is really just critical to begin with. I think I'll zoom out and just talk about if someone said, oh, my face is twitching, what my thoughts would be in that case. I think probably for me, knowing if it's just localized to the face versus perhaps if what the patient has noticed with twitching elsewhere on exam could be really helpful, because I think really thinking about like where potentially this neuromuscular hyperactivity is happening, if it's really localized versus more diffuse, would be how I would start approaching that schema. If it's really quite localized, I probably try and take just an anatomic approach about, well, what could be happening in the sort of nerve and muscle area of the face, including the cranial nerve, and involving some of the musculature there. Versus if the patient's having more diffuse twitching, I might start to think about, well, what could cause myoclonus? And I'm saying the word myoclonus, which really just means, right, muscle having clonus. And that opens up a huge differential of medication related, electrolyte related, and here's where Kirtan's thought about the CKD comes in, other systemic disease processes in general. Ultimately, myoclonus has an incredibly broad differential if you look at it, and that's why knowing focality, thinking something about specifically neuromuscular in a region versus knowing if it's happening in multiple muscle groups of the body and thus related to something more systemic, would be kind of my first sort of approach when parsing out the history from this patient. Probably keep moving forward there, and we'll see if Kirtan hops back on.
Anne Marie, anything to add to that?
No, I think I was just kind of thinking about the same thing, like, could it be related to the CKD? And if so, kind of what could be some of the things driving it? So thinking about, like, could it be related to like toxin buildup? kind of a similar phenomenon is sometimes like asterixis that you see, or could it be electrolyte mediated, whether hypocalcemia may be related, or due to like hyperkalemia or related to magnesium or something else. So those were just kind of some initial thoughts I had.
Awesome. Okay, so here's a little bit more of a story. So he had been doing well for a while, was just kind of being monitored for his, hypertension CKD. But then a week ago, he had been admitted to the hospital and diagnosed with a gluteal abscess. He wasn't like super sick, but it was a big kind of subcutaneous and slightly deeper extending abscess that actually required a drainage. So he got the IND, he got some antibiotics initially, and then based on susceptibilities, he was discharged on levofloxacin, and overall had improved, was on the mend. And the twitching actually started just 2 days ago. Initially, it was just on his face. And then occasionally he would also have a jerking of his extremities. He had never experienced anything like this before. And it actually quickly got worse and worse over the next day and a half, to where now it was almost constant and like completely uncontrollable. And obviously, understandably, extremely bothersome to him. All the while, the butt was feeling better. He didn't have any systemic infectious symptoms, and the pain and the swelling had decreased in the area. And nor did he have any other symptoms, whether neurologic or otherwise. Nothing kind of focal inflammatory, no pains, breathing was fine. His self-perceived sort of mental status, cognition, and other kind of neurologic functions seem to be intact on history. And I'll just round out the rest of the history section. Nothing else significant on past medical history. The meds, in addition to the recently prescribed levofloxacin, included sodium bicarbonate, calcium vitamin D, sevelamer, I appreciate the spelling of sevelamer close to my name. He was on some nifedipine and just like some other vitamins, and I think that's about it. No family history of anything like this. He was retired, not currently working, just lived at home with his family, didn't smoke, didn't drink, didn't use any drugs. And no known drug allergies or adverse reactions. I'll stop there.
And maybe, I haven't seen Kirtan pop back on yet. Hopefully he'll be able to connect, but maybe I'll just give some general comments on what do we do when someone has just had a hospital stay and they come in with a new issue. And then Anne-Marie, if you're available, if you want to maybe then give more specific thoughts on like this guy's particular diagnosis based on what we have, we could break up the discussion that way. I think the fact that this gentleman was here 1 week ago in the hospital makes it very difficult to divorce what happened then, both in terms of his diagnosis and all the treatments he got from his current symptoms. They're just extremely located close in time. So it really makes me want to find out what happened in the hospital stay. And this is the case where you really, really hope that you've got a very detailed discharge summary, as well as set of laboratory data and what treatments were given from the hospital stay. So kind of in particular, I think a few things that I would focus and look on about the prior hospital stay are the following. Certainly laboratory trends, because a lot of people have mentioned a big category of electrolyte problems that could happen. Seeing if anything was evolving as an abnormality back then, because we have the lab data there. Similarly, his renal function in general, we're told he has CKD5. I would be very curious if during the hospital stay that renal function started worsening, or if there was any particular insults to the kidneys that could account for worsened renal function now. as a particular driver for, I think, what we can now call it's myoclonus, because it's in the face as well as other limbs. So specifically things that could really hurt his kidneys then that might not appear in his renal function numbers to now could be any hemodynamic instability. If he had hypotension from sepsis for the abscess, wondering about if acute tubular necrosis could have developed. Certainly any medications, including what his antibiotics were during that hospital stay, that could be potential nephrotoxins. Of course, we know he's on the levofloxacin now, but what did he get then that could be a particular problem? And then any other kind of just procedures or interventions that he got then that could factor into the kidney function right now. But let me just stop there and say, I think the history is going to drive out of the diagnostics and treatments he got, but kind of see Anne-Marie, like specifically, are there a set of kind of diagnoses or conditions that pop up now that we have a little more info?
Yeah, thank you so much, Steph, for that awesome overview. So kind of when I'm approaching myoclonus, which I don't see very often, granted, but I'm kind of thinking about, is this a primary cause? Is there some reason that there could have been some sort of like seizure or primary CNS insult, or is this more a secondary cause? And then, you know, if it's a secondary cause, as Steph, like the awesome overview, is it something related to the recent infection or hospitalization? So, you know, I think a really good neuro exam would be helpful here. It seems like there aren't any other kind of causes and no known hypotension that could lead to like brain ischemia or anything like that. You would think that that would be more obvious. So I'm kind of thinking about more a secondary cause just by the history. So here, kind of thinking about secondary causes, you know, of course, he does have cardiovascular risk factors, I assume, with CKD being a big cardiovascular risk factor. So that certainly could be a consideration. But then also, as was mentioned, thinking about what's the kidney function, has there been a change? You know, also wondering about the liver function, but then also thinking about you know, the electrolytes is already mentioned, and then the medications, which is a big one in CKD because you don't clear medications as well. So it's very possible to have a medication that could cause an effect. One of the big ones I think about in CKD is gabapentin, which can, you know, too high doses can lead to coma, but can also be associated with myoclonus. But I don't really see that on the medication list. And I don't really see a lot of other culprits besides the fluoroquinolone, which could have, it can certainly, you know, lower the seizure threshold and cause an encephalopathy, but I believe it can also cause myoclonus. So I'd be really curious, you know, how long has the fluoroquinolone been on? Is it appropriately dosed for the degree of CKD, and has it ever been taken in the past and tolerated? And I'd probably just go ahead and take that off the table by stopping the fluoroquinolone and then observing if things improved. I'd also be kind of curious about the infection. Fluoroquinolone is not the first thing I'd think about for a gluteal abscess. So I'd be curious about kind of how it was chosen, if it was known what the bug was and what the susceptibilities. Maybe it's the Pseudomonas infection that was susceptible, but maybe there's something we're not treating here, and the myoclonus is due to an infection. So I'd want to do a really good exam and ask kind of further about that. Would be kind of just some initial thoughts, as well as looking at all the labs carefully.
Amazing discussion so far. Thank you. Let me tell you about his exam. So the vital signs, in short, were totally normal. But he had a striking appearance as soon as you walked into the room. And I will try to just sort of imitate the best I can, like what his face looked like, which was just constant little twitching of various, you know, muscles of facial expression, just like, you know, his lips going up, his basically everything that cranial nerve 7 controls was just like, you know, just taking turns contracting. And then he also had a lot of jerking like myoclonus, like it was like he was constantly just, like dancing, just twitching all the time. And they were all not coordinated. They were all sort of myoclonic jerks, just with a really impressive diffuse distribution and high frequency. Otherwise, he was able to kind of communicate, talk. Normally, his mental status was normal. He was able to walk and participate in the rest of the neuro exam okay, which was all non-focal. His JVP was a little bit elevated, but his heart and lungs were pretty clear. He had a mild systolic murmur he had before, and his abdomen was soft, and the abscess on his butt looked like it was healing fine. Anything that I'm missing that you're curious to ask on exam?
Did you palpate, like, do the sign where you like hit the face to see if there's worsening with that?
Thank you very much. We tried to elicit a Trostek sign, but honestly, like, you didn't need to tap his facial nerve in order for his muscles to spasm in response to that. And it was really hard to tell, like, whether his twitching was like secondary to your tap, or not, because of how frequently he was doing it with unprovoked, essentially. So with that, let me actually go through and give you guys the initial lab workup.
Can I ask two questions? I may have missed it. Were there other neuromuscular kind of excitability signs like hyperreflexia or kind of clonus?
Clonus, no. He was a little hyperreflexic, but again, if I remember correctly, it was also just like hard to separate that from some of his just like jerkiness in general. But he was a little bit hyperreflexic diffusely, yeah.
And then this is more history than exam, but since we're worried about his renal function and how progression plays into it, had he had changes kind of in urination, just volume?
I don't remember, but that's a good segue into his lab work. Okay. So his initial CBC was normal except for a hemoglobin of 10. His Chem 7 sodium was like 135. Potassium was 5.5. But chloride, bicarb were fine, and then his BUN was 60. Sorry, it was 96, and his creatinine was 6.6. And glucose was normal, and the BUN and creatinine were right at where they were, a week ago when he was hospitalized.
And was that number stable, or it had progressed even from prior?
No, he had been in the 5s and 6s for months.
Okay.
Yeah. His calcium, his corrected calcium was 7.1. His FOS was 4.5, MAG was 2.2. Albumin was a little low, but the rest of the LFTs were fine. EKG, chest X-ray were unremarkable, and I'll stop there.
Kirtan, you're back.
Yes, I'm so sorry. I don't know what happens on Wednesday. I mean, even on previous Wednesdays crashed. All through the week it's fine, but on Wednesday it goes off. So yeah, so lots of data. So I will just summarize it quickly for the sake of time. So initially I was telling that the twitching, is it related to the CKD itself, or is it related to the underlying cause of CKD, right? So for example, if the patient has diabetes and that led to CKD, then is the twitching related to diabetes or it is related to CKD? Now we have lots and lots of data. So talking about the common things first, the patient's calcium is a little bit low. So we know that hypocalcemia can cause tetany, and sometimes it can even cause neuromuscular irritability, and that can cause the twitching. So that is one thing to consider. Apart from that, our patient's creatinine is very high. So now we know that in patients with CKD, you get uremia, and uremia can cause so many things. So uremia can affect the nerves themselves. So it can cause neuropathy. It can even cause neuromuscular junction disorders. So it doesn't classically cause myasthenia or something like that, but it just impairs the conduction at the level of NMJ, and it can even affect the muscle. So that can cause the twitching. Apart from that, we know that uremia can cause encephalopathy. And uremic encephalopathy has got so many varieties. Sometimes patient present with delirium, sometimes patients with global confusion, and sometimes they can present with movement disorders, because uremia also affects the functioning of the basal ganglia. It usually happens in the terminal stages of the illness, but still it is something to consider that whether we are dealing with uremic encephalopathy or not. And then we talk about the toxic causes. The patient was started on levofloxacin. So this is, I learned this from Aaron only on Neuro VMR, that Aaron loves about cefepime. So he always tells us that cefepime can cause encephalopathy. And then he even told us in one of the VMRs that ciprofloxacin and levofloxacin, so the fluoroquinolone group of antibiotics, is also notorious to cause encephalopathy. And if that is the case, then we can also explain the twitching by that. Apart from that, the patient also had myoclonic movements. So if I'm not wrong, we have something known as AMRF, that is action myoclonus in renal failure syndrome. So again, as we talked about earlier, that uremia can cause the neural irritability. So myoclonus is also one type of irritability only. So both twitching and myoclonus can be affected by the CKD, and uremia may be one of the reasons for that. And I guess what else we have? Phosphorus looks fine. Yes, so those are my thoughts. Now, can you help me that what are things that I missed and how to approach it further?
I don't know how much I can help. That was just beautiful and a wonderful discussion of kind of the interplay of the uremia in particular on the neurologic system. Really just beautifully said. I would say the labs in this case make me ask the question that comes up a lot in real life. That is, how abnormal do abnormal labs need to be to cause problems? So the reason I was asking first about the kidney numbers, what is the chronicity of the BUN and creatinine change, is because the BUN being close to 100, the creatinine being close to 7, very, very abnormal. And absolutely a major, major category we need to think of in this neuromuscular excitability. But what gives me pause is how long they've been here, right? Zavin told us that the creatinine at least has been at this level for months. Presumably the BUN has been in a similar range. So with that stability, even though it's abnormal, can we really blame the BUN and creatinine? We'll see. Similarly for the calcium, I would be curious kind of what has been happening with the calcium in the past for him as a first question.
It was almost exactly in the same range at the last hospitalization a week ago, as well as going back weeks and months.
Interesting. And so that's sort of a short segue into sort of the calcium phosphorus balance that can happen with chronic kidney disease. I saw some people mentioned in the chat, you know, he's on sevelamer, which is a phosphate binder, because phosphate builds up for many reasons in CKD, including kind of decreased clearance and a tertiary hyperthyroidism that happens. But it can bind calcium when it's there in excess. And so a common pattern in patients who don't have their calcium phosphorus balance managed in chronic kidney disease is a very high phosphorus with a low calcium. Now, he may have been in that situation before, because we actually noticed and see calcium and vitamin D are on his medication list. So someone probably has noticed before hypocalcemia as a pattern, and thus has been trying to manage his phosphorus not being too high, and then certainly his kind of vitamin D levels being appropriate. I mentioned that because, again, there's a chronicity there to the mildly low calcium. So I again ask my question is that calcium low enough to cause this degree of myoclonus? And is it new enough to cause what is a very new problem? I'm not sure. I'll look to the chat for wisdom on that. I guess the final topic I'll briefly comment on, which Kirtan brought up, is that the fluoroquinolone itself, an extremely commonly used antibiotic, but has many common and uncommon adverse effects, really as all medications do. you guys can help me in the chat, but when I think of common things that we discuss with fluoroquinolones are certainly the tendinopathy, which doesn't happen frequently, but in high-risk patients is a devastating consequence that can really change people's lives. So tendinopathy would be a particular risk in someone like you with renal dysfunction, not relevant to this case, but very important to think about. The kind of channelopathy effects that fluoroquinolones have include QT prolongation. So it's good to know that his EKG is unremarkable. As far as we know, there's not a prolonged QT, but that's something we often think about, particularly when other people are on QT prolonging drugs. Kirtan gave us a beautiful list of some of the neurologic complications, such as neuropathy and encephalopathy that can happen with fluoroquinolones. And then very commonly, like with all antibiotics, we worry about diarrhea, both just general GI upset as well as Clostridium difficile infection. But so to me, those are some of the kind of most common things to think about with a fluoroquinolone, and I may be missing something. But I think in addition to the renal function, in addition to the calcium being abnormal, we do have this medication exposure that's ongoing that we really will need to be careful that isn't part of the picture.
So Anne-Marie had asked a question that I intentionally didn't address. It was an astute one. So in real life with this patient, we were thinking exactly, with the same framework that Kirtan, Anne-Marie, and Steph just shared, except we couldn't come up with it in a moment. We got a lot of help from UpToDate in order to come to this. But of course, a patient who is having myoclonus and neuromuscular irritability, who has, a BUN of 96, who has a calcium corrected that's 7, it was very easy to try to wonder whether they're contributing. But for exactly the reasons that Steph mentioned in terms of the timing and the chronicity and the severity, we weren't satisfied with that, that differential. Now, he did get some IV calcium in the ED before we ever saw him. And we actually just gave him some in addition, and basically like his calcium was in a normal range at one point soon after his presentation, and it did not help his symptoms at all. So Anne-Marie's question was the dosing of the levofloxacin appropriate? And it was actually. So it was prescribed at a dose of 500 milligrams every other day, as you do in patients with this degree of renal function. So that's, and I will also say that we, in consideration of this potentially being now a symptomatic advanced CKD, we also initiated some steps to potentially start dialysis. Although again, at this point, let's say we're about 18 hours into the presentation, and his symptoms haven't improved very much at all.
With both giving calcium and then he got some dialysis?
No, we were like, planning to place a catheter and stuff like that. So what are your thoughts now?
I don't know. Anne-Marie, do you want to jump in to give Kirtan a break?
I suppose, although Kirtan speaks so eloquently. So I think some of the things I'd be thinking about is that I still would not be satisfied that it wasn't the fluoroquinolone, because in CKD you're going to have longer half-lives, and so I'd be really curious about when the last dose was, but I still would be kind of wondering about that. I assume it's probably held at admission. I'd still be wondering about infection, although the normal WBC and the lack of fever and other infectious symptoms does appear to make it less likely. And then I'd still be wondering about either some sort of primary neurological process as well, or some sort of CNS process. So, trying to decide if needed to get further neuroimaging or things like that. I think I would want to maybe talk to neurology and have them evaluate, but I'd be a little bit hesitant unless there's other changes on exam to think about doing like a full neurologic workup until I felt like the fluoroquinolone had been out of the system for a while. And then again, just kind of wanted to review if there was any sort of sensitivities on that abscess and why specifically the fluoroquinolone was started. But please kind of add other thoughts.
Yeah, Kirtan, anything you want to add to that? Awesome, Anne
Yes, no, yes. I guess we are on the right track. I mean, we know only this much data that whether it is due to uremic encephalopathy, whether it's due to fluoroquinolone. And lastly, as we mentioned earlier, that whether it is something known as action myoclonus renal failure kind of thing, and even uremia can cause progressive myoclonus. So is that related to that? Because apart from jerking and twitching, the myoclonus is also on the radar. So we need to figure out why the patient has such drastic myoclonus. And lastly, I don't think it is likely here, but sometimes you get neuromyotonia syndromes. Usually they are paraneoplastic syndromes. So they are not related to CKD. But again, the pathophysiology is same. You irritate the neuromuscular junction, and that's why you end up getting twitching and myoclonus. So we can look for those autoantibodies if we don't find any evidence here. And on MRI, probably if we get the MRI of the brain, and if we find the evidence of any foci, then maybe we can look for those autoantibodies. But as of now, I'm right there with Anne that is the fluoroquinolone appropriate and is the uremia contributing to it? And if dialysis improves the condition, that we can be assured of the fact that maybe uremia was contributing at least part of the syndrome, and that's how dialysis can improve it. So now let's see what Seven has to tell us.
Good work, everyone. So the reason I think the prior team had chosen a quinolone is because the abscess had grown a staph that was susceptible to quinolone, as well as some gram-negative rod that I don't remember, but that was the reason to not sort of treat gram-positives more elegantly, avoiding some of the myriad side effects of quinolones that Steph mentioned. So we took a closer medrec history with this gentleman, and it turned out that while the levoflox was prescribed and written with the right dosing every other day, that he had not been directed clearly enough to take it every other day, and he was taking it daily. That's what he had understood that he was supposed to do, and that's what he was doing. The last dose he had taken was, I think the morning before he came in, and over the next basically 36 to 48 hours, 24 to 48 hours, his twitching gradually got less and less, and then went away completely at about 48 hours after presentation. All the while, not having been initiated on dialysis yet. So that was the diagnosis of quinolone-induced sort of neurotoxicity, myoclonus, that was a result of medication communication error resulting in accidental overdose in the setting of poor renal function. So I have my reasons why I just learned so much from this case, but we have some time if everybody wants to kind of reflect and share their favorite learning points from the discussion or from just the experience.
Kirtan, do you want to go first, and then Anne-Marie and I can go?
Yes, sure. So thank you so much for that case. I learned so much. And again, thanks to our dear friend Aaron. And so this is what we learned on VMR. So there, in fact, Maria presented one case of cefepime encephalopathy on one of the global VMRs. And in that teaching points, the Gabriela and Maria both mentioned that apart from cefepime, what other antibiotics are more likely to cause encephalopathy. And in that list, at the top was levofloxacin. So that stuck in my mind that how fluoroquinolones can cause encephalopathy. And even at our own hospital, whenever we prescribe fluoroquinolone, we have to be very vigilant because we had 3 cases of levofloxacin-induced status epilepticus at my hospital within last 3 months. So it was so severe that even if I had to forget it, I can't forget it, because when you see the patients in front of you taking levofloxacin and that's seizing like anything, we gave lorazepam, we gave phenytoin, we did everything, but the patient won't stop seizing at all. So it was so drastic. And in one case, we even had evidence of demyelination on MRI. So it was very, very confusing that why fluoroquinolone can cause all these things. So it was a nice reminder. So from this case, I will again remember that why in patients with CKD, we always have to be aware of the fact that even if CKD is not contributing, maybe the patient is not taking the medications in the right way, and the CKD will just compound that problem if we have got drugs which are cleared by the renal system. So thank you so much for that. And now I will remember that how fluoroquinolones can do all these things and can mimic uremia too.
Wow, thank you, Kirtan.
Thank you so much for presenting this case, Savan. I think it's such a humbling reminder about how important it is just to spend time talking with the patient and really getting that good history, and that how easy it is to kind of misunderstand. It seems obvious to us because we do it every day, but is really, really difficult, especially for someone who's on a lot of medications, to understand like, oh, I'm supposed to take this every other day and not daily. And so just to like take the time with patients to try to make sure that we're giving them clear and good instructions, because when I'm taking a medication, I struggle to take just like a once daily medication, and that's all. So I can't even imagine with having a large pill burden, with stuff that's dosed at kind of weird or infrequent intervals, about trying to like understand taking it correctly. And so I think there's just such power in that. But thank you so much for presenting this case. And I also love the reminder that a lot of times that things that happen can be a lot of like iatrogenesis too. So don't forget that.
Beautifully said. I'll just make a brief comment about specifically thinking about medication frequency when selecting them. I think I've tried to be very conscientious to stay away from medications, particularly antibiotics, that require many times per day dosing, right? If you can pick someone a 2 times a day antibiotic, that's so much better than 4 times a day. And I think I've gotten in my mind that less frequent dosing is always better. But here's a situation where less frequent dosing of every other day, in fact, was confusing and problematic. And you can imagine, even if this was explained, it's very easy to kind of forget which day you've taken it and either take too much or too little of an every 48-hour medication. So I think for my reflection is less frequent dosing is better to a point, but making patient-friendly regimens really kind of includes the good counseling, like Anne-Marie said, and I guess, really taking a pill 1 time per day, man, if you can achieve that with your regimen, that really seems to be the easiest to kind of stick with and make sure everyone gets right.
Thanks, everybody. I love this case for all of the reasons that and all of the great teaching points that you made. The only thing I'll add is just how much kind of an element of clinical reasoning in managing and helping this patient was just differentiating like what's possible versus what's plausible versus what's probable, right? I think so many of our patients are so complicated that you can pick so many different narratives that like sound pretty good, right? Like, okay, he's twitching and his calcium is 6.5 corrected 7, like that must be it, right? But when something doesn't make sense, which is like this new symptom is like brand new and fulminant, right? Whereas the narrative we're telling, like the calcium has been there all along, right? You have to kind of pay attention to say, like, for that reason, this story is not a good sell, right? And keep looking for alternative narratives. And then the element of that Anne-Marie sort of mentioned so beautifully, which was, there's all these other things that could be going on. Kirtan mentioned paraneoplastic syndromes and autoimmune encephalitis, like CGAD, like all these other things can cause myoclonus, right? But when you have one theory, the testing of which just requires like taking a deep breath and like waiting, right, for 12 hours or a day or whatever, and just seeing what happens. A lot of times that patience is really appropriate before you just cause even more complications, right, with new tests that you're doing or new treatments that you initiate. So I think it also was a lesson to sometimes be patient when the patient seems to be stable. Thank you. Thank you for discussing and for the chance to present the case. Gabriel, if you want to just kind of summarize whatever else you want to summarize and bring us home.
Hello, can you hear me?
Yes.
Hello?
Yeah, we can hear you.
Awesome. Awesome case, David, and amazing discussion, guys. I learned a lot. I had no idea fluoroquinolones can induce myoclonic movement. So let's start with the teaching points. So we had this gentleman of 60s that came because of twitching and has a previous history of chronic kidney disease. So we were wondering about if this may be due to electrolyte abnormality, such as hypocalcemia or hypomagnesemia. We have to wonder about if the patient, how is his hemodynamic status and the medication that he had been using. In this case, he has been using fluoroquinolones, and we were also discussing about those side effects, and we have to take in consideration fluoroquinolones can induce encephalopathy. Other side effects are tendinopathy, QT prolongation, clostridium difficile diarrhea, and as in this case, myoclonic movement. We were discussing about myoclonius. Emery told us about if this could be a primary neurologic insult or secondary, such as infections, electrolyte disturbance, and medications. We have to remember that sevelamer is a phosphate resin binder, so we were linking that maybe this patient can have hyperphosphatemia, and then the hyperphosphatemia can induce the hypocalcemia and then the twitching. Kirtan also taught us about the uremia neurologic manifestations. They that are neuropathy, neuromuscular junction disorders, encephalopathy, and we have to take in mind that the basal ganglia are affected. We then studied hypocalcemia. Hypocalcemia can be divided into big categories: PTH mediated or non-mediated. In this patient, that most probably is non-mediated because the BUN was really high. Another etiologies are vitamin D deficiency, magnesium deficiency, and another rare cause is pseudohypoparathyroidism, calcium deficiency. Clinically, we can have a patient with hypocalcemia with the Schefter and the Tertius sign. And then finally, Kushal taught us a pair in the chat about MRF that means action myoclonus renal failure syndrome. So thank you a lot, guys, for connecting me, and have a great day.
Thank you.
Bye, everyone.
Take care.